Good evening, everyone. My name is Janet Griffin, and I am the Senior Director of Alumni Relations at NYU Meyers College of Nursing. And it's my pleasure to welcome you all to this very special occasion as we celebrate the 25th anniversary of the Palliative Care Nurse Practitioner Program. Today, we honor a quarter century of dedication, compassion, and innovation in the field of palliative care. This milestone is a testament to the countless lives touched by the tireless work of nurse practitioners to provide comfort and dignity during some of life's most vulnerable moments. As we look back on the program's achievements, the accomplishments of its alumni, and the impact they have made, we also look ahead with hope and determination to continue advancing palliative care education, practice, and advocacy. Thank you for everyone to celebrate this meaningful journey. I would like to introduce you to Dr. Dorothy Wholihan, who is our clinical professor and the director of the Palliative Care NP Specialty Program here at Rory Meyers College of Nursing. Dr. Wholihan earned her bachelor's in nursing from the University of Pennsylvania and her master's in nursing from Yale University and a doctor of nursing practice from George Washington University. Dorothy has over 40 years of nursing experience with extensive advanced practice in oncology, pain management, and palliative care. She maintains a clinical practice as a nurse practitioner with a palliative service, which she established at the J.J. Peters VA Medical Center in the Bronx in 1997. She holds national board certification as a primary care nurse practitioner, geriatric nurse practitioner, and an advanced practice hospice and palliative care nurse. She has been named as a national fellow in palliative nursing and a fellow of the American Academy of Nursing. She's written numerous publications and book chapters and is a national and international faculty training for the End of Life Nursing Education Consortium. She's across the nation and in countries as far away as Singapore, the Philippines, and Kenya. Dr. Wholihan is the recipient of the Distinguished Teaching Award from both Myers and the wider university level, which is very prestigious. She is a palliative care
Is this being recorded, Tom?
Yeah.
She is a palliative care clinical resource and expert educator for of nurses, students here at Myers. I'm going to turn it over to Dr. Wholihan, who is going to guide our program tonight.
Thanks, Janet. Thank you for that great introduction and welcome everybody. I am so excited to be celebrating this year. It feels like just yesterday when we got this program started, and now we're hit to 25 years. So I'm really excited about speaking to you today about some of what we've accomplished and some of what you have accomplished as our alumni. Before I start, and I want to also thank you for coming out on a Tuesday night in the winter. I put these flowers on my background to remind us all that it's not going to last forever. So I appreciate this on the end of a busy Tuesday that you're with us. So before I start my remarks today, I want to take a second to acknowledge another part of palliative care at NYU. We're going to be talking about the clinical program today, but I would be remiss if I didn't acknowledge and appreciate the researchers who look into palliative care at Myers. We have a very robust and well-regarded program of research here. And so I just wanted to make sure that we acknowledge the work that our nurse scientists are doing alongside us, that science that guides our practice. So tonight, what we're going to do is talk a little bit about oh, wait a minute, let me get moving here. Here we go. About what palliative clinical nursing looked like at NYU and look a little bit at the evolution of the profession of palliative nursing, and then aligning what we've been doing here at the school, and maybe talking a little bit about what we are thinking about and hearing what you're thinking about, and we look towards the future. So I think we need to start with this basic premise that advanced practice nursing and palliative care are a perfect fit, that advanced practice nurses are trained and educated from a systems perspective, and this is very much a systems role within the hospital setting, and that as nurses, with our background, our multidimensional training, our interdisciplinary focus, our whole person way of thinking about people, are really the best suited to be leaders in this field. And we have been and continue to be. So I think it's important for us to look at our past to understand where we are today and then think about planning for the future. So let's take a quick look at that. Now, I was surprised and delighted that many of the people who signed up or registered for this event more not familiar names as well, alumni perhaps, but aren't working in the field of palliative care. So I think we need to start at the baseline here in terms of defining what palliative care is, because of course, there's been some misperceptions about it in the past. So what is palliative care? It's specialized, interdisciplinary, team-based care for patients who have serious advanced illness and their families. So this is a team of providers that can provide support for patients and families at any point in the illness trajectory, alongside active medical treatment. We focus on quality of life issues, symptom management, and that's multidimensional symptoms, physical, psychological, social issues, spiritual issues, focusing on family as the unit of care. And most challenging, our work involves helping patients and families to articulate and understand what their values and goals are during this illness experience, so that we can match the medical treatment with what's important to them. So remembering this all, we think about hospice, because frequently palliative care has been thought of as hospice care. And hospice is all of these same principles, but focused towards the end of one's life. And so palliative care includes hospice. Hospice is part of palliative care, but not all palliative care is hospice, anywhere along the illness trajectory. Okay, so getting that as our basic point of reference, let's look a little bit about the history of palliative care and see how much palliative nurses have been involved. And so really, it wasn't until the 60s that people started really thinking and writing about palliative care. And so we can think of one of the earliest works done by Elizabeth Kubler-Ross, who was a psychiatrist who wrote this book on death and dying, which I'm assuming many of us have read, whereas she interviewed with her medical students a bunch of people who were approaching the end of their life and came up with some themes. And she's the one who developed this theories of the stages of grief, which we have all heard of. The most important influence in the development of this field came from Dr. Cicely Saunders, and you can see a picture of her here in her nurse's cap on the top. Cicely Saunders was a social worker who became a nurse, who became a physician, and she was the first to start a hospice, an institute or a unit devoted specifically for people at the end of their life. And I like to think of Cicely Saunders as, and you can see her smiling face on the right there as she was older, I like to think of her as a walking interdisciplinary team. But the fact that she started out and has a nursing component within her is an important point to think in mind as we think about how palliative care has evolved. So Dr. Florence Wald, who was the dean of Yale University College of Nursing in the 70s, brought hospice to the United States and established the first hospice facility up in Branford, Connecticut, which is still going strong. And I was privileged enough to do some of my master's thesis work when I was up at Yale. So it became obvious pretty soon that this was a valuable part of patient care. And so in the 1982, it became recognized and developed into a Medicare insurance benefit, which is how we think of hospice now. It's an insurance benefit that is geared towards people's care at the end of life. Fairly early on, hospice nurses started to organize and develop the Hospice Nursing Association, which is now known as Hospice and Palliative Nursing Association. Okay. And then what happened to make us think a little bit more out of the box in terms of moving past just end of life care with these important concepts? And what happened was in the middle of the 90s, we started hearing a lot more and learning a little bit more about the experience of people who had serious illness. And part of that came in the public image and part of it came from the profession. And so it started out with the emergence of a physician named Dr. Jack Kevorkian, who was actually not a clinician, but a pathologist by training. And Jack Kevorkian became known as an early activist for physician-assisted suicide and helped people to self-inject to themselves and kill them and die, basically through an apparatus he set up in the back of his VW minivan. So he got a ton of attention in the mid-90s. You see him there on the cover of Time magazine. And so the consumers out there, patients and people in the public, were starting to think and worry about what this looked like. And then we heard about a major study that came out called the support study. And the support study stands for the study to understand prognosis for outcomes and risks of treatment. And it was designed to try to address some of the issues that people with critical illness and advanced illness underwent when they were in the hospital, not at the end, necessarily at the end of their life, but hospitalized. And what that study found was some very disturbing data that more than 50% of people died with moderate to severe pain levels, that symptoms were not well managed, that doctors didn't know what their patients' desires were. They didn't know if their patient was DNR or not. Many people died in intensive care units. People were financially bankrupt from their illnesses. So it really was a call for us to recognize that we needed to do some work here earlier on than the very last stages of life. And so philanthropic funding began to come out after this. And the AACN, the American Association of College of Nurses, said, hey, we got to get this into nursing education. And so in 1998, the first graduate programs of nursing were developed. And I'm really proud to be able to remind us all that the first nurse practitioner in palliative care program developed here at NYU by Dr. Deb Sherman, and we'll talk a little bit about that in a minute. At the same time, clinical nurse specialist program was developing out in Ohio at Ursuline College. So then we start looking at the next decade and seeing how really palliative care took off. In 1999, an organization called CAPC, the Center to Advance Palliative Care, was founded, and it's founded up through an institute at Mount Sinai Medical Center here in the city. And the purpose of this organization was really to support and provide resources for people who wanted to start palliative care programs in their hospitals. Remember, back then we didn't have any of these services. When I started my program at the VA, we didn't even have the word palliative care. I would walk around and ask nurses, who's really sick here? And they called me a hospice consult team for looking at people with advanced illness. So this organization was a really important resource. And then the next year, a nursing resource developed, which has had an immense impact upon the field. ELNEC, the End of Life Nursing Education Consortium, developed a train the trainer program that was co-founded by Dr. Betty Farrell, really our foremost palliative care leader in nursing, and the American Association of College of Nurses. And what ELNEC does is it provides train the trainer programs for nurses across the country and across the world. And they're also celebrating 25 years. And I've been happy to be involved with them since 2010, when I got involved as a national faculty member. That program has touched millions of nurses and is in now 92 countries. So it's been pretty effective. Excuse me. And then the VA got involved, and the Veterans Administration has been at the forefront of palliative care. And at this point, they said, every hospital in the VA system must have an interdisciplinary team for palliative care, must have inpatient beds for hospice and palliative patients. And they have continued to push palliative care agenda. So they've been very supportive in the field. Deb Sherman, who was, again, our pioneer here, later developed the certification, the board certification for advanced practice to lend our credentials. And in 2004, we got our National Clinical Practice Guidelines, co-chaired again by a nurse. At this time, nursing research was really starting to come out, and one research article, which was a landmark study, which is continuing actually in some form today, came out of Dartmouth, where a nurse named Maria Baquitas started looking at nurse-led interventions for people while they were still at home, and the effect, and found a positive impact on quality of life, and really was the beginning of telephone work to look at palliative care and keep people out of hospitals. And her work continues now in Alabama. I guess she got tired of the cold and moved south. Of note is that in the latter part of this decade, the palliative care was starting to be recognized important by everybody, and it became a medical board specialty in 2006. And this has truly impacted the taking off of palliative care because, well, we know the power in hospitals does lie in medicine, and that has helped to promote the development of palliative care teams. Within hospitals, at least. And then, of course, in 2009, we got formal recognition and some standards for pediatric palliative care, which has really come of its own. Okay, so if we look at the more recent time, what's been happening in the field? And a landmark study came out of Mass General Hospital in 2010 that has really changed and spearheaded our work. An oncologist named Jennifer Temmel did some work in her outpatient palliative care clinic where she looked at integrating palliative care early on in one's disease trajectory. Remember, that's what we've been trying to do all along, to get this quality of life focus throughout the trajectory of one's illness. So Temmel and her cohort and her colleagues, including advanced practice nurses, created a randomized control study where patients with advanced lung cancer either received regular oncology care, which might or might not involve a palliative care referral, or regular oncology care, chemo, immunotherapy, whatever, with concurrent palliative care at the same time. So when you came to see your oncologist, you also saw your palliative care person. And what they found was what you might imagine: better quality of life, less depression, which we know is a prognostic indicator, less use of aggressive therapy in the last weeks of life, more hospital utilization. But what they found, which was surprising, was patients who received palliative care from the beginning lived almost 3 months longer. And we were all saying, if this was chemo, everybody would be getting it, because that's a long amount of time for people with advanced illness. So this really changed the whole perspective, the whole gestalt of palliative care, because before, when oncology and palliative care would sometimes butt heads and you just got sent to palliative care when there was nothing left for you, now even the oncology clinical practice guidelines have changed to incorporate in advanced illnesses palliative care from the start. The IOM then came along and said, great, we're doing better at this, but we still have a long way to go. And one of the recommendations there was educate people more. So in 2016, a bill was presented to Congress called Pacetta, which sounds like an Italian appetizer to me, but it stands for Palliative Care Health Education Training Act, which really tried to call for funding for widespread education. Unfortunately, it's still sitting in Congress and committee. So for those of you who have advocacy slants, this is something to root for, and we don't know what's going to happen with the current climate. But we do look ahead and think. The ANA comes out in 2017 saying nurses should be at the forefront. Nurses should be leading this care. At about the same time, we also realized that there just aren't enough specialists to provide this care for everyone who needs it. And in fact, we started asking ourselves, does palliative care, is it a specialty, or is it part of what all nurses should be providing and all healthcare people? So we basically came up with this term then called primary palliative care, right? So we have specialists who are the consultants for complex cases and teach, but pretty much everybody should be incorporating primary palliative care. And so the AACN, along with the LNEC folks, came up with these competencies for what people should be teaching advanced practice nurses and undergraduates about palliative care for everyone. And that has influenced what we're doing at the college, as we'll see in a minute. So where do we look? What's it looking like now, right? So this is an interesting graph from the CAPC people. And you can see here, this is basically the number of hospitals that have palliative care teams. And we can see that we're doing pretty well. The green is larger hospitals, 98% in nonprofit, 100% in public hospitals, a little less with the smaller sizes, and certainly less in the for-profit hospitals. And that is partly because palliative care services have been seen as cost savings more than revenue generating. And so we need to continue to document our financial worth, and try to advocate for private hospitals to recognize the value of this care. So, but currently, basically, palliative care is now an accepted specialty within most medical centers, certainly the larger ones. More patients are dying with hospice services in place every day. We're up to about 50% of all people in the country use hospice now. We're moving palliative care upstream into the community, and we'll talk a little bit about that more later. But what I see happening nationally in terms of higher education is that palliative care programs within graduate schools is really slowing. And what's happened is, and I think that we can attribute this to the growth of the mandated DNP. So I think what's happened in many schools of nursing is in the graduate schools, when you're adding a DNP as the required degree, the credit crunch kind of closes out the specialty opportunities. And so I'm incredibly pleased that we continue to have a very robust program here. And we'll talk a little bit about thinking about that as we go along. So take a breath. That was a whirlwind tour of what has happened in the field in general. And now I'd like to take a little bit of a look at home and what we've been doing at NYU, and aligning what we've been doing, thinking in the back of our minds about what we saw developing in the wider field. And this is my kind of timeline trajectory. It took me forever to line up all these little circles, but we're going to refer back to this graphic as we continue to talk about NYU and what we've done. And I want to point out there's these little like explosive star types of things are points on the timeline when I'm going to call upon alumni of our program to unmute themselves and give us a 1 to 2 minute perspective on what they're doing along the line, so we can share some of the successes and the perspectives of our alumni, because that's really what this whole night is about. So we remember going back to the start. This is Deb Sherman, who started our program back way back when, 25 years now. And Deb's work did her doctoral work here in HIV care, and has gone on to do a lot of research on quality of life issues. And what she basically did was, when the funding came through and the attention started being looking at palliative care, and she recognized we need to do something formal here, she developed a robust curriculum for people to become palliative care nurse practitioners. She took it to the State Board of Nursing and said, if I educate these people, will you license them? And they said, yeah, sounds good. And so she did. And then people started coming from other states. We would educate and give them these degrees, and they would go back to their State Board of Nursing and do the same thing. And that worked well for a while. We got a few states like New Jersey were pretty long to come along. But what we noticed then was that there were a few states that just were holding out. Texas, New Hampshire, they weren't budging no matter what we did with them. So what we eventually had to do is we took the palliative care program and we attached it as a co-major or dual major with the primary care program. And so our nurses could be licensed as primary care nurse practitioners across the country, and then go out and work in palliative care. And so what was it like to work in palliative care back then in the early days? And what I'm going to do is ask one of our alumni to speak up. Rob Smeltz is one of our earlier graduates, and Rob currently is a nurse practitioner, and the assistant director of palliative care, of the palliative care program at Bellevue. So I'm going to ask Rob to unmute himself and give us 1 or 2 minutes of his perspective on what it was like starting up programs.
Yes, thank you, Dorothy. I would be remiss to not begin by just acknowledging the impact that you've had on this profession. You didn't show up on that presentation or in that timeline, but you are weaved throughout that, and have had such a significant impact, not just on my career, but so many of the careers of the people here and throughout the country that are working as nurse practitioners in palliative care. I started off as an oncology nurse and then became a hospice nurse. And I think it was in 1999 and this was in Pennsylvania, that I heard about a program starting up in New York for nurse practitioners in palliative care, and a great opportunity to bring hospice type care to people sooner. And that's what I did. I came to New York, and I had the privilege of learning under Dr. Sherman and Dr. Wholihan. And from there, I was privileged to be able to start the palliative care program at Jamaica Hospital. Got that started. 2 years later, they were asking me to do the same thing at Bellevue, and that's where I've been ever since. That was in 2007. And we now are a team of 3 nurse practitioners when it was just me, and we have several physicians. We have a fellowship program. We've been wanting to start an NP fellowship here, but that has been very challenging. I'm not somebody who gives up easily, so maybe someday. But you know, I clearly walked into the right profession because I'm here 20 years later and still loving it. I'm actually back at NYU as a student, getting my degree, my postmaster's as a psych NP. And I'm finding that the two go really well together. I really like the communication part of the work that I do, and bringing therapy to that work, I think, is going to help set the right tone for the next 20 years. Thank you again, Dorothy. What a privilege to have been able to go through this program and work in this field and work among such an incredible set of colleagues. I haven't gotten to work with many of the people here, but several of them, and never always left with the sense that palliative care and hospice brings a great group of people together.
Thank you, Rob. I see we're growing old together, the two of us. We've been together a long time, and I appreciate all your kind words. And I wanted to just point out the interesting thing about Rob's work in the beginning. Remember, what was happening in the beginning there was that hospitals weren't 100% sure about this service. So they hired nurse practitioners. In general, pretty much all the programs in these years were being started by nurse practitioners, because the hospitals knew that we could communicate well, that we kind of knew everybody. We interacted with social workers and chaplains and physicians well. We knew how to work systems, and we were less expensive. So why don't we try with a nurse practitioner? If it doesn't work, well, it's not as expensive as hiring a doctor. Not that they could find any doctors who knew palliative care in the same way. So I think that it was really it was challenging in the beginning for all of us, for Rob and for those of us starting, because people didn't even know what this was. And the fact that Rob's team at Bellevue has grown to probably one of the most substantive teams in the city. I just love to go over there and sit at the team meeting where everybody is represented, child life and art therapy, and everyone is sitting at the table. So the work you're doing is pretty amazing. And I thank you very much for chatting. All right, let's go back to our timeline and take a look at what's been happening after that. So in 2008, the LACE model came along, and I think many of you are aware, this restructured, this was the state boards of nurses, restructuring how nurses were educated, certified, credentialed. And what happened to us there was palliative care became a specialty that could be added on to any of the population focus programs we had. And that was a boon for us in palliative care, because now we're teaching a cohort of students who come from FNP, acute care, primary care, pediatrics, and mental health as well. We have a handful of those through the year. And so it really opened up the opportunities to reach more specialties. And so I'd like to think about the specialty sequence and ask our next alumni to speak briefly about her experience. Mallory Fossa is the nurse practitioner. She's a pediatric nurse practitioner who's working currently at the Connecticut Children's Hospital. Hi, Mallory. Thanks for joining us. Can you give us a minute for your perspective?
It's really exciting, and I echo all of Rob's sentiments towards you and the program and your growth that you've done. I think your second pediatric specialized nurse practitioner, and I really came to NYU knowing that I wanted to do a combination of pediatrics and the subspecialty program that you were offering in palliative care. I started out after graduating and going out to Children's Hospital of Los Angeles, where I was out there for about 4 years, and now I'm back on the East Coast, back in Connecticut. And, I think that it's really been amazing. You kind of spoke about the trajectory of palliative care in general, and peds palliative care has kind of always been there, but much slower going at all those kind of accomplishments and growth within institutions. When I first started in 2015, it was primarily in large academic pediatric centers that palliative care was offered. And I would say over the last 10 years, we've really seen pediatric palliative care grow to outpatient, to telehealth, to hospices. And the nurse practitioners, I think, really play a vital role in that growth. And I think it's really amazing to see how nurse practitioners are partnering, like in the adult world, in a lot of the vital research in pediatric palliative care. They're either doing their own research, they're doing QI, and I think because of the interdisciplinary nature of the teams, they're really encouraged to kind of partner with their other colleagues in the work that's being published. And I think the growth of pediatric palliative care is just really blossoming at this time, and it's really neat to be a part of and to see. So I really kind of look forward to seeing the growth of it continue, and it's really an amazing and sacred space to hold with our patients and families.
Oh, thanks, Mallory. Thank you so very much. And congrats on all the great work you are doing. We are incredibly proud to have our pediatric palliative nursing colleagues go along with us. And it's true, it was slow to get started. People don't like to think about kids that sick, but such an essential service, and you're doing amazing work. Thanks. Okay, so let's look on what's been going on. In 2009 at the school, it really started pushing and getting into our simulation exercises. And this was a turning point in education. Those of you who came before had no idea how much we tortured people in this sim labs. But it was one of the most dreaded and nerve-wracking experiences, but it provided students to work with, and in palliative care, we don't work with mannequins, we work with live actors. And so it gives our students the opportunities to practice really tough, serious, sensitive, emotional-laden conversations with patients, the harder work, I think. And I want to thank here Dr. Chuck Tilley, who came from our program, alumni of our program, and really, because of his palliative care perspective, helped to develop simulations throughout all of the programs, not only within palliative care, but for instance, a really innovative one in midwifery on perinatal demise, which we were able to publish on, and assisting Dr. Brennan to do a great palliative extubation simulation, which involves dealing with families and difficult times. So the simulation has really changed some of the way we educate palliative care. In 2011, we had our first DNP student with a palliative care focus, and I've seen a continual growth of palliative care nurses interested in getting DNPs, and we'll touch upon that as we go along. One of the things that happened in 2016 is when these G-cares, when we got these competencies for primary palliative care, remember, integrating palliative care into all of the everyone's practice, it became obvious to us how important it was to open this opportunity for specialist work to anybody. across all the populations. And so now what we see in our program is we have people who come like Rob or Mallory who know they want to work in palliative care as palliative care specialists. But then we also have students and alumni who know they might want to be an intensivist or work in primary care, but want a solid palliative care expertise. And so I'm going to introduce now our next speaker, Rosemary Gorman. Rosemary is a graduate of our program. Are you there, Rosemary?
I'm here.
Oh, great. So Rosemary, actually, when I called her or I emailed her and asked her, she said, I'm about to I'm retiring now. Do you still want me? And I said, yes, 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 because the work she has done has been really innovative and really important. Can you take 1 minute for us, Rosemary, to talk about your practice as a primary care nurse practitioner with a palliative care focus?
Certainly. And I also echo all my thoughts about you, Dorothy. You are amazing. And my time at NYU is one of the things in my life I'm most proud of, and I value it every day. I was a nurse for almost 30 years before I even heard about a palliative care nurse practitioner. I was watching the same patients over and over be readmitted for chronic conditions. And I realized that palliative care was desperately needed. So the palliative care program at NYU became my goal. Initially, I thought I would be part of a traditional palliative care team in a hospital. However, that quickly changed. For my very first rotation in primary care, I worked in an urban primary care practice, and I had a plethora of patients with multimorbidity, and they were living longer. However, their quality of life was poor. They were hospitalized frequently, and they just had such poor quality of life with a huge symptom burden, all of the indications for a person that needs palliative care. So my capstone project reflected on my experience in primary care. As a result of that, I was asked to be contribute to the Oxford textbook of advanced practice palliative nursing. Somehow I didn't think that I would be an expert at anything, but I was able to do that. I eventually specialized in geriatric primary care. I established a home service because I did not think that it appropriate to turn over our sickest patients to a visiting physician group. And I was responsible for their management. During my geriatric primary care, I was introduced to a nurse practitioner clinic called Healthy Lives. Their focus was to treat patients. Most of them were all patients at risk for rehospitalization with chronic disease, heart failure, COPD. These nurse practitioners, instead of sending patients to the emergency room, they would treat them in their office, follow them closely, and prevent any hospitalizations. Because of this, their hospital has never incurred a Medicare readmission penalty. I eventually became part of this team. This was my last job. It was probably one of the best things I ever did. They learned palliative care from me, and palliative care and advanced care planning became integral in the care of every single patient that we treated. The patients trusted our honesty and appreciated the effective management of their symptoms. Our ongoing assessment and acknowledgement of their decline, both physically and their functional status, made for a seamless transition to hospice for the patient, the family, and all of the practitioners. I was sorry to leave.
Rosemary, thank you so much for all that. To hear of all that you have accomplished, it's amazing. The thing that stuck out for me here when I heard you speak is this one line: they learned palliative care from me. And that's how our alumni have impacted so much more, so many more people than the patients they directly touch. Thanks for sharing that and enjoy your retirement. You deserve it, my dear. Okay, moving on. Let's think about what happened then. So we're talking more about the generalist and primary palliative care. So we started a graduate elective for anybody in the graduate school who wasn't necessarily in the specialty who wanted to learn more about palliative care. So this has been a really fun course to teach because I'm teaching midwives and primary care folks and all sorts of people who are interested in doing what Rosemary talked about as so important, integrating it in their practice. At this time also, we started seeing what Rosemary's talking about, more and more palliative care going out of the hospital setting into communities, into the community care, and this care is being run and developed and by nurse practitioners. And so I'd like to ask now for one more of our alumni to talk about her experience in community-based palliative care. Lindley, are you there? Lindley Leone is currently, she's an alumni who's done pretty much everything.
I'm here. You can hear me,
Hi,
right?
Lindley. Yes, hi, I see you.
Hi.
So Lindley has worked in inpatient, in community palliative care, and now I guess she's in hospice and working with the regional hospice in Danbury. But I'd like to take just 1 minute quickly, Lindley, for you to share with us some of your thoughts about community-based palliative care.
Definitely. Thank you so much, Dorothy. So I've been a nurse since 2008. I did a lot of first I started at a New York City hospital and I was doing med surg and ICU level care and noticed a lot of holes in nursing and a lot of places where people weren't really understanding their illness. They weren't getting good symptom management. They were having very bad deaths. And I was lucky enough to meet Dorothy, join her program, changed my entire career. And I am just so blessed to have met you and to have done your program. So thank you. After I graduated Dorothy's program, I was on palliative care consult teams for probably like 8 years or so. I needed to get out of the hospital after COVID, and I felt like preventing older adults from being admitted to the hospital, especially after COVID, was super important. So I joined a community-based palliative care program, which was primarily geriatric based. It started with the best intentions, this company, where you were supposed to see older adults in their homes, prevent them from getting readmitted, talk to them about how serious their illness was, get to know them, have a cup of coffee, talk to them about what they understood, kind of really get to know them in their home environment. And overall, after a while of getting to know them, prevent them from going to the hospital if that wasn't within their goals of care, and sort of it started off with really good intentions, a beautiful thing, seeing home-based older adults and teaching them about their illness, which ultimately would then lead to them understanding it better and coming up with a better long-term plan for them. But what happened, and what happens with a lot of these programs, is it got bought by an insurance company. And then the metrics became super important. And so instead of being able to spend 60 minutes sitting and really getting to know someone and understanding what was important to them and really gathering intel on what they understood and what their value systems were, it kind of turned into you rushing your visit as fast as you could because you had to see 9 or 10 patients in a day because the insurance company was timing you. And so what started as just the most beautiful idea kind of got a little messed up when insurance company got involved. And I think that's happened with a lot of the programs, unfortunately. But I think that there is so much work to be done in the community, and older adults are just getting older and they're getting more and more of these serious illnesses all at the same time, right? And these are the people that are ending up in the emergency room. And these are the people that are, ending up hospitalized when they really could have been home and they could have been transitioned into some sort of better level of care, whether it be hospice or a facility or whatever makes sense for them at the time. So I think there's just so much amazing work that could be done there. I just don't know how it's going to be done, if that makes sense.
That makes sense. Thank you so much. Thank you. So that was a fascinating look into it. And what's happening in community-based palliative care is exactly what Lindley said, is that we know this is the concept that is important and that works in research, that the earlier we get involved is better. But the financial reimbursement of how to do this in the community is still being looked at, and different models are being explored. And I think what's really important here is that is that nurses maintain a presence there in terms of helping to navigate this, because we are the ones who know the impact and know what's involved. And so speaking up and advocating, like I know Lindley did for all of her patients and her time there, is important. And many people who are in it for a profit driven have to be counteracted to make these financial models work. So to be continued, this discussion on community-based palliative care. I think it has a future. I think it's really important, and there's a lot of challenges still. Okay, let's go back to what our timeline looks like, because of course, as Lindley alluded there, COVID hit us right in the middle. And one of the things that became clear in COVID from the palliative care perspective is that two of those three main pillars, right? We were still, of course, working on symptom management, but these were super sick people in isolation. We needed to support families who weren't allowed in the hospital and to talk about goals of care in really sick people who often couldn't communicate. And so we ended up, many of us, on the phone. And I spent COVID basically doing volunteer work, having cold call resuscitation discussions with super sick families of super sick people, which was incredibly challenging. But one of the good things that came out of COVID, if you think about it, is that telehealth is now has been recognized as having real value. And so I want to go on and ask one of our alumni who's doing this, Dr. Sheila Pandy, who is one of our graduates, is currently working as nurse practitioner and advanced practice education specialist at Memorial Sloan Kettering. And part of her practice is in telehealth. So Sheila, can you come on and give us a minute of your time?
Hi, Dorothy. Hi, everybody. Again, amazing talk so far. I'll keep it short. So we were doing palliative care where I am now at Memorial Sloan Kettering Cancer Center before the pandemic. And when the pandemic occurred, like Dr. Wholihan said, this practice grew exponentially. We did it inpatient, and all of our ambulatory clinics are currently hybrid. So we can offer telehealth visits for those people, like Dorothy said, who are too frail, who are too sick, who live in rural areas in the tri-state area, and in line with state controlled substance prescribing laws. And the government has caught on to say this is really important, and there's legislation now to continue to push the forgivance that the DEA has given, so we can continue to do controlled substance prescribing through telehealth. I am 100% independent in my clinic, and so are the other nurse practitioners. And we carry more than half of the total ambulatory visits for our service. So we are really invaluable, and we're able to be independent because of the training that we got, like from this program, and because we've learned through programs like NYU how to advocate for ourselves. So I will just say briefly, when my first NP job at NYP Columbia, I had an attending on the first week say to me, "Where were you trained, and where can we get more of you?" So I'll keep my remarks brief and let you continue. Thank you.
Thanks, Sheila. Thanks. So one of the things that's really interesting too is that Sheila is helping to teach our students telehealth. So it's part of the curriculum now because it's part of the reality of care. So I'm delighted to have her on board with us. Thanks, Sheila, for those minutes that you gave us. Okay, so what's happened more recently, we were fortunate enough to be able to develop an undergraduate elective to continue our primary palliative care education for our undergraduate students. And this is a course that's so much fun to teach because a lot of these students are not coming from a frame of reference with experience with seriously ill folks. And so it's not only an educational, but I think of it as an inspirational course where I'm trying to get undergraduate nurses interested in what palliative care is and how important it is. Let's go to the most recent piece of what we've seen happening. And that was last year where we were able to develop and start and pioneer our first integrated DNP and palliative care specialty student. And what we did here is we had a alumni of our program, an FNP alumni named Jennifer Abate, who came to me and said, "I work in the MS clinic and we don't do palliative care there, and we really need to. Can you teach me palliative care? And I said, yeah, I'd love to, but why don't you come and get a DNP too at the same time? Because then you can make really impactful change in your system. And so she did, and she volunteered to be our first pioneer in this, and it was incredibly successful. And what she has done is create an entire new job role for herself. And I want to ask Jen if you can sign on, Jen, and give us a minute reflection. Are you there?
Hi, Dorothy. Can you hear me?
Yes. Hi, Jen.
Hi. So during the dual degree DNP and palliative care specialty sequence, after observing the need, we performed the literature review. We looked to see what were other people in this field doing? Were they doing anything like this? Was there research to support something like this quality improvement initiative? And we found that other places were doing things like this, but in other specialties. So like cystic fibrosis and oncology centers, there were nurse practitioners who were making these embedded clinics, but nobody had ever done this before in neurology, and especially not in MS. And so with the help of Dr. Wholihan and many great mentors, I was able to successfully establish a nurse practitioner-led embedded palliative care clinic within the standing multiple sclerosis center at NYU, where I still work full time. The biggest challenge was really selling this concept to my colleagues and the entire staff. So neurologists all the way to administrative team members, due to the common overwhelming stigma that many of us face, which is selling that palliative care does not mean hospice. And I had to really receive that acceptance that palliative care could be useful to our population for people with all stages of MS, not just those at the end of stage. And so there were many reasons for this pushback, especially in neurology, and it's even cited in the literature that we know that healthcare professionals often, especially in neurology, they don't want to have patients lose hope. But we know as palliative care providers that actually the opposite happens. So through providing case study examples of current patients that we had in the practice, showing the literature how this could be useful, and then demonstrating with really firm examples of clients which we were already seeing, how this service could be helpful, I was able to get some traction. And this further increased the positive experiences that my colleagues were having with this, and then the patients were giving great feedback. But we also had a lot of positive objective data showing things such as these burdensome neurological symptoms that patients often experience who have longstanding MS. More of these symptoms were being identified and managed per visit in a palliative care follow-up than just compared to a regular MS follow-up. And they were also being given a space to discuss their concerns and their worries for the future with somebody who's also an MS specialist and understands their disease and their trajectory. So it became very successful. And in addition to my regular responsibilities treating people with MS, I run the clinic and provide the palliative care to patients with MS. It's now about 20% of my practice, and the service is now open to all MS sites within the institution. To the best of my knowledge, this is the only NP-led outpatient palliative care program within NYU, the only one in New York City for MS specifically. And I just think this is such a special event to celebrate you, Dorothy. And I echo what everybody else before me has said. You've been the best mentor I've ever had. And I feel very lucky to have been in this program with all of you.
Jen, thank you. Thanks for those kind words. I'll send you my check in the mail. I'm getting lots of nice accolades today, but truly the accolades go to you because she has created an incredibly impactful and important role here. And now we're trying to start a movement and see if we can impact other clinics within the setting. Because many of us know that although oncology has recognized palliative care, all of these other chronic illnesses, the pulmonary illnesses, the end-stage liver disease, the neurological problems, all of these are rich environments for getting palliative care nurse practitioners involved. Jen, thank you. Congratulations on that great work, and congrats on your doctorate, Dr. Abate. I'm so excited about all this stuff you guys are doing. I can't believe it. So lastly, I want to finish this timeline, and I know you guys are hanging in with me really well, to kind of come back, look at, if we start at the beginning of our timeline, we see NPs running and leading teams, and I want to end up with another team. So in the New York City area, it's an incredibly medicalized healthcare system we are in, but we've had NPs leave our city and move to all parts of the country and do innovative stuff that really empowers nurses. So I want to ask Nina Barrett, who I haven't seen in ages. Nina, can you come on? Nina is now the lead NP. Is she with us? Hi, Nina. Is at the University of Colorado, Longs Peak Hospital. Nina, can you take just 1 minute to share with us what you're doing out there in Colorado?
Sure. So I was trained in New York City, and it's really nice to see so many of my classmates and colleagues. Hi, guys. 2014 is representing on this call. Let's just say that. So I did move after a couple of years working as an NP at Columbia, gigantic hospital and 9 ICUs. For many reasons, moved out to a medium-sized town in Colorado and worked at a small community hospital. Felt like I just fell from the moon, both personally and professionally. I mean, you cannot find a good falafel, but just the change from tiny community hospital to, from Columbia to tiny hospital was a huge culture shock. And after a couple of years there, a new hospital opened up in our town that was affiliated with UC Health, which is like the academic system in our state. And I was hired to start the palliative care program as an NP, which was I'd only ever been a worker bear. I didn't know anything about program development, but I did have good mentors, and I always asked myself, WWDD, like what would Dorothy do? And used CAPC and some great, wonderful mentors within the program, and just realized that it's like one foot in front of the other. And turns out I have strong opinions, and there's certain ways that I like things done, and that was a benefit of starting my own program, is that it could look like how I wanted it to look and what I thought high quality palliative care should look like. Some successes of the program is, although I did have to work all by myself through COVID, which was grueling and awful, I was counseled to keep really good data as I was going, and as a result was able to make the case to grow the team. So that cost savings case. And so we're now a team of 3 NPs. Not everybody works full time, but 3 NPs. Just recently was able to add a palliative care social worker because it's interdisciplinary, and that was like the hill that I died on. We've now expanded the palliative care services to a sister community hospital that had no palliative care whatsoever, and now we're providing tele-palliative care to that hospital, and also started an inpatient hospice program, which the hospital loves because it reduces mortality, which is kind of gross for that reason, that's why they love it. But in my mind, it helps patients who otherwise would have just died in the hospital and gotten no support after, their families would have not gotten support after death. That they now get that and an extra layer of support while they're here. So there have been a lot of really wonderful growth areas, and it's the happiest I've ever been professionally. It's a great work-life balance.
Great to hear. Great to hear. Thank you so much. It's great to see your face. And it's wonderful to end this timeline looking at nurse practitioners running teams and doing amazing work just among ourselves. So that's pretty amazing. So let me think about, as we've spent these last few minutes together, what are we taking away from our history lesson here? Nurses have always been at the forefront of hospice and palliative care. Nurses are innovators, and the culture of who we are makes us the best leaders. And so let's continue for moving ahead. The problem is what we know isn't always translated into practice. And I just want to bring up a scoping review that I found looking at 18 different works where the results were basically what we expected, that NPs are able to provide great palliative care in numerous settings, increasing quality, improving the care, reducing cost, addressing social issues, improving care coordination. We know this. However, not everybody recognizes this. And what this found, the scoping review found, is that sometimes other disciplines didn't recognize our role clearly. We didn't recognize our role sometimes. Generalist NPs who were trying to do palliative care weren't always comfortable doing it. And a lot of this came down to the fact that there's just not enough education about palliative care and palliative care nursing. And so what I really want to think about is to be sure that we continue to try to think of ourselves as the backbone of palliative care, and to advocate for that, and to continue educating people along those lines. And I think that what are we doing here, and what are we thinking about here in terms of moving ahead? We want to continue to expand our generalist education so that our nurse practitioners who are going out who are not specialists will feel more comfortable to meet some of those needs identified in that scoping review. So we're going to continue to expand our electives. We're going to continue to work with our clinical partnerships, getting the students out there to role model, doing education outreach. Anybody want a palliative care speaker? Call me, either myself, or alumni, or a student will be there in a second. And then this concept of that Rob mentioned about fellowship development. What I see happening is, as some of these graduate programs are diminishing, hospital-based fellowship programs across the country are growing. And so maybe there's a role for us to partner with some of our clinical partners to develop fellowship programs. And then, of course, continue to integrate the palliative care curriculum into our population focus. I've been invited to speak to the family nurse practitioners. We were successful with getting a midwifery simulation together. I'm delighted to be speaking every semester in nursing issues and trends now. And so, as the American College of Nurses new master's essentials is saying, palliative care is one of these 4 basic concepts and has to be threaded through the curriculum. And then, of course, our new integrated DNP program, which is really an important announcement that should be made here today. What is that going to look like? What does that look like? If you know anybody who's interested in coming back to school again, who's out there working and has an interest in palliative care, we are integrating the palliative care specialty content into the DNP curriculum with 9 additional credits, 3 classes, but interspersed among it in a manageable way, 300 hours done in a very individualized way. It's what we learned with Jen, who was I'm so thankful to have had her, to realize that we can do clinical work in innovative new ways. And then, of course, a project that's focused on palliative care. Recently, I was very privileged to be able to co-lead a national panel of faculty educators who are working in graduate education on palliative care. And we came up with a set of standards and recommendations about what we think should be included in palliative care specialty programs, because beforehand that had never been enunciated. And I tell you, working with this many people, academics, was not an easy fact. It took years to come to consensus, but we did. And we're hoping that these guidelines can help future programs either continue or to grow or to start in. And what about you as individuals? How are we going to address some of the challenges? And one of the things I want to just keep telling people is to find your voice. I mean, people like Nina going out into the Colorado and saying, oh, I was not at all surprised to feel you had strong opinions, Nina, but I'm glad that you were spoken up, because those were translated into real patient care outcomes. And one of the things that I see happening in this city, at least, and across the country in other areas, is since our medical colleagues have become so involved, we see departments of palliative care turning into departments of palliative medicine. And so in terms of finding your voice, I want to remind you that language matters and that this is interdisciplinary. And so we need to make sure that our professional identity as people trained in an interdisciplinary, multidimensional manner comes out and people recognize our worth as leaders. So wherever you are practicing, find your voice through a variety of different mediums, whether it's teaching yourself. Come and do a lecture with me. I'd love to have you. Developing an area of expertise within your area, like Jen did. Or we have another wonderful alum, I don't know if she's on the call, Sarah Romanelli, who started her own practice in aging, healthy aging, and from a palliative care perspective. So I want to be sure, if there's anything you want help with, you want brainstorming on, you want work with, we're here. I'm here, and I'd love to hear from you. So I want to just say, in closing here, well done, alumni. I am so delighted to celebrate you guys. And I wanted to say, keep going, keep in touch. We have a party planned on the 27th. For those of you who can come and dress up and raise a toast to who we are and what we've done. If you cannot come, send a picture of you and your kids and your work or whatever, so that we can refresh ourselves and inspire each other. And so I'm going to stop there and thank very much my speakers tonight. It was a delight to see everybody, and I hope you had an informative evening. Thanks.
Thank you.
Janet, was there anything that we needed to?
I just wanted to, if anybody has any questions or you want to come off mute and make any comments, say hi to Dorothy in real time instead of in the chat, feel free to do so.
Will
Or
this tape be available?
Yes, the recording will be put on the Meyers YouTube website.
Thank you.
great. Thanks, everybody.
Thanks, everybody.